Thank you.
Thank you very much. That was a nice presentation, but we have to follow. We have to continue. And the next speaker is Imran from Germany. Challenging case of recanalization of heavy calcified external and common iliac artery by critical limb ischemia using hybrid technique. Please welcome.
I am so thankful to Dr. Nas Said that I was invited to this conference. So today I would like to present a case under the title of Challenging Case of Recanalization. Challenging case of recanalization of heavily calcified external and common iliac artery by critical limb ischemia using hybrid technique. So it concerns male patient, age 67 years old. He has risk factors, hypertension, diabetes mellitus type 2, and he has severe coronary heart disease. He presented in 2021 with Loriche and Fontaine stage 2B left, and we did for him common femoral thromboendarterectomy with patchoplasty, and we did remote endarterectomy with external iliac artery left, but he has bilateral occluded chronic SFA. In 2022, as part of his PAD, he has also carotid endarterectomy. And he presented to us in the December 2022 with Loriche and Fontaine, stage 4 with wrist pain. CT angiogram was performed and showed widespread arteriosclerosis, atherosclerotic occlusion of the external iliac artery, common femoral artery SFA as known. External iliac artery was atherosclerotic and arteriosclerotic, and this was the cause why the patient has worsening of symptoms and presented to us, in addition to his chronic SFA occlusion. So I just want to show you. This is the aorta as part of his CT. You can see the arteriosclerosis, circumferential calcification of the aorta. And this is bifurcation, both iliacs. This means that arteriosclerosis also extends to the both common iliacs, circumferential, which makes the artery not clampable. And here you can see on the right side complete calcification. This is combination of atherosclerosis and arteriosclerosis. This is like the rock in about 6 millimeter length, under which you can see here arteriosclerosis and the eccentric atherosclerosis with calcification. Then you see the thrombus in the external iliac artery on the right side, and how this calcification extends to the bifurcation. So I took the patient the same day for operation. We're a team, we participated, but I started the operation. I do right common femoral approach. The right common femoral artery was heavily calcified. I dissected till the profunda, soft area, the 3 branches of the profunda. Then I tried to recanalize upward. I just want you to see this CT, also the widespread arteriosclerosis. But we have revascularization procedure in the same day, failed recanalization. So we did a retroperitoneal approach of the right common iliac bifurcation. We used balloon occlusion catheter because the artery was was very hard and not clampable. Then we started to do piecemeal removal of the calcification. Then we did patch at the common femoral bifurcation. We did endarterectomy down also in the femoral, and we did patchoplasty above and below. Then control intraoperative angiogram. So it's obvious bleeding from the patch side occurred as we tried to recanalize the residual stenosis. I will show the picture. So the bleeding which occurred after the treatment was not controllable. This is also because of arteriosclerosis and very fragile artery after removal of calcification. Intraoperative angiogram showed severe high-grade eccentric stenosis and extravasation, as we said. So, but we could pass the eccentric stenosis by wire, and we inserted the Bentley graft, 10 millimeter diameter and 6 millimeter length, and we did control angiogram. It was good. So this is intraoperative angiogram. So eccentric calcification of the external iliac begin. And this is the extravasation during our trial to recanalize. And this is after Bentley graft. With no leakage, and there was harmonic filling of the iliac axis. So I just want to present this case to send a message. We have two types of calcification. We have arteriosclerosis and atherosclerosis, and we have to differentiate, and we have to see this in CT angiogram. This picture is very expressive. We can see on the left the calcification. The arteriosclerosis is always concentric, and the eccentric, the atherosclerosis, this is a plaque deposition, subintimal, which will enlarge after this, always eccentric. So we have two types. And if you see a patient with complete occlusion and combines the both types, it's very unlikely that the drug will pass during this complete occlusion. So my points, I concluded, in the presence of complete arterial occlusion and both types of calcification, endovascular recanalization alone is very unlikely to succeed, and direct surgery removal will be required. Circumferential arteriosclerosis makes the artery not clampable, and the Fogarty occlusion catheter is mandatory to control the inflow and backflow. CT angiogram preoperative is essential to grade the calcification with bone window. MR angiogram plays no role. The aim of surgery to open a gate for the guide wire to pass, not completely remove the calcification, otherwise we will lose the arteries. The preparation of corresponding sized covered stent is essential. Thank you.